Hey everyone, this is Josh, and today we're going over concepts of critical care transport. So, you're about to be introduced to what CAMES is and the rules and regulations that they outline for agencies to be CAMES accredited in relation to the medical crew, the administration, mechanics, pilots, everything, communication, technicians, all of that. So let's dive in. We're going to change pace here a little bit and leave the history side of medical transport and talk about critical care transport and some of the intricacies of flying and transporting patients by ground in today's world. Critical care patients, this is the definition here. These are patients who are experiencing a life-threatening illness or injury that requires continual monitoring and care by specialty-trained physicians, nurses, and paramedics. This patient is obviously very sick, and I actually have incorporated this photo into a slide coming up that I want to talk about But these are critically injured, critically ill patients that you're typically, basic trained paramedic or nurse or physician are not trained or capable necessarily of handling. It's not because they're dumb, they just don't have the resources and have the training that they need. Let's take a look at the definition of a critical care transport. So it is the transporting of a critical care patient by ground or air from an emergency department, critical care unit, or a scene while providing the same level or a higher level of care as the patient was receiving at the sending facility or agency. Your job as a critical care transport provider is to provide the same level of care or higher that this patient was receiving by physicians, nurses, techs, pharmacists at the facility you're picking them up from. That's a pretty tall glass to fill. And so keep that in mind as you're studying this material throughout this course and preparing yourself to be an excellent critical care transport provider. Commission on Accreditation of Medical Transport Systems, also known as CAMES, here's their mission statement. I'll just read it for you. Who's dedicated to improving the quality of patient care and safety of the transport environment for services providing rotor wing, fixed wing, and ground transport systems. The next slide tells us a little bit more about that. Okay, pronounced CAMES. The T is silent. I know, it doesn't look like it, but it is. This is a not-for-profit accrediting agency. So their job, or what they do, is they go out to different critical care transport agencies, whether you're ground, whether you're air, and they evaluate your program. And they evaluate it based on their standards, which are exceptionally high. They're going to look at the management of your organization, the different levels, the training, and the processes that are in place for employees and management to communicate with each other. They are looking at the individual medical personnel. They're looking at the pilots. They're looking at their experience, their training, their knowledge. They come out to your facility and they spend 2 or 3 days there, and they go, they look through your paperwork, they look through your reports, but they also go to the individual providers throughout the organization and ask them questions and evaluate them. So this isn't just a generic evaluation sitting back and reading through reports. They're actually going out there and meeting the members of the team. And so as a member of the team, you need to make a good impression on them. You need to be knowledgeable and know what you're talking about. Their standards are supported by measurable criteria to measure a program's level of quality. So it's all based on, like your SMART goals. It's measurable. they're looking at data that's pulled in through reports and different evaluation models that they have. They look at your communications. They'll go to your flight center or communication center, what your protocols are as far as your aircraft and vehicles. They go to the shops where they're maintained. They look through their records. The quality management program, that's another important one, and we're going to talk a little bit more about that coming up. But what steps does your program take to constantly be improving? And then they take a look at your policies and your procedures. These are a few of the things. Their standards are revised periodically because the medical transport industry is constantly growing and changing. And so I think, we've looked at here, they look at your program from top to bottom, every aspect of your program. And if you pass their accreditation process, then you are a CAIMS accredited agency for 3 years until they come around again. I'll tell you, this is a stressful time for everybody. You believe that you are a CAIMS capable program, but you don't want to be on duty when they come out. It's a little bit stressful to realize they're going to come and ask you some questions and expect you to know the answers. Critical care transport teams may be composed of different members from different backgrounds and with different levels of training, certification, licensing. These are some of the team members that you may see on a critical care team: EMTs, critical care paramedics, registered nurses, respiratory therapists. Those are the common ones. There are others, and these ones are typically not members of the flight team or the critical care team. They go along on the transports in special circumstances. And these are the perfusionists, surgeons, neonatologists, pediatric intensivists. So we'll look at those in a little more detail coming up. There are a variety of different team configurations that you may come across here in the United States. Nurse medic is probably the most common. Nurse and nurse RT, those are very common when you're dealing with pediatric patients and neonatal patients. Nurse physician is more common in Europe. And then these are some other combinations you can have here. Medic is seen in EMS agencies versus the hospital and community-based agencies typically have a nurse in there somewhere. There's not one configuration that has shown to be better than others. There's no standard configuration. The thing I like about the nurse-medic combo is you bring these two different sets of experience that I think meld well. You have the paramedics who are used to working out in the field under no direct supervision. They have to think outside the box. They have to make decisions without consulting a physician, and they have situations that require them to use their judgment and their imagination, and yes, imagination. And I think one of the most important ones is they know scene trauma. They know how the incident command system works. They've been in chaos, and they feel comfortable in chaos. And then what the nurses bring is they bring typically a higher level of education. They've had more studying time in school, and they've worked around physicians. They've taken care of critical patients for years, and they're comfortable with ventilators and infusions and those more advanced, managing those patients who have more advanced interventions. And then I failed to mention the other thing that medics bring is they come to the table already having experience in intubating and criking and putting needles in the chest. When the nurses, that's new to them, at least to perform. They've seen them, but they haven't performed them. It's interesting that they've found that having a physician on a critical care transport team does not have much effect on outcomes. And one reason for this is because the scope of practice of the flight team, a paramedic, a nurse, or whatever your combination is so high that there's really not much more a physician can do that these flight teams can't do. It's different with a surgeon, and we'll talk more about that coming up. But there are things that surgeons can do that, no, don't even think about cutting that patient's arm off to get them free. Or maybe do. I don't know. There was a study that was in Europe that showed outcomes of trauma patients, and I don't know what their control was and how they ran this study, but they found that patient mortality, these trauma patients' mortality, was 32% when they were treated by a physician, 28% when they were treated by a medic, and 26% when they were treated by an EMT. The factor that they decided is what increases mortality with the higher level of training is longer scene times. The doctors, they can do more, they know more, and they want to get it done right there out in the field, when what they really need is to get to a hospital where they can have, surgeon and blood. So I thought that was an interesting study. I think that these memes are funny, and I think they're also very accurate. If you look at this top left one, if you know any respiratory therapists, why do poop when you can do peep instead? They hate poop. They hate poop more than any other person on the planet, which is kind of funny, because you find that a lot of nurses feel the same way about snot, whereas respiratory therapists don't mind it. So the one on the right here, the paramedic, I love the confidence of this paramedic here. And I think it's important as medics that we do come with confidence. You're out in the field and you don't have anyone else to rely on but yourself, generally speaking. So, and then I love the bottom right one here. This just shows the aggressive attitude of nurses, and ICU nurses in particular. This shows the purpose of EMTs and kind of, I think, what a lot of people think about them. They're just there to carry the bags, to do the work. This meme is great. Here we see some of the requirements for EMTs to work in critical care transport. They're kind of just the workhorse there. They will do everything that you need them to do for you. They're your tech, I guess, would be the equivalent in the ER. Whatever you need done. And, they're good at it. On critical care transport teams, their jobs are to drive the vehicle. So EVO, emergency vehicle operations, they need to have that training and be able to drive safely. I feel a lot safer flying in a helicopter than I do with some particular ambulance drivers. So drive safely, EMTs, and whoever else is driving the ambulance. Paramedics, they're so confident. Let the flight medic handle it. We talked about these certifications already. And then we talked about what paramedics bring to the team, which is what I think makes the paramedic-nurse combo great. It's a good mix of specialties and experience. The registered nurse, typically they are seen as the higher level of care, so it is standard for them to be the designated leader of the flight team. And then you go through here the other stuff that we already talked about as far as certifications are concerned. And once again, they bring the skills that are needed to manage the interfacility transports. I'm telling you, this nurse-paramedic combo is fantastic for a helicopter team. Don't touch the ventilator! Respiratory therapists are the best. They run the ventilator in the ICU, and then you get the doctors who do their rounds, and they come in and they're like, let's adjust this patient to this or that. And then the without telling the respiratory therapist, and then they come in and somebody's jacked with their ventilator. Anywho, respiratory therapists can function as regular members of the critical care team and sometimes as temporary members when they're needed only for specific missions. They're typically used for interfacility transports because they bring with them experience in an ICU, in an ER, in a neonatal ICU. That's where they're comfortable and that's where they excel. So they're utilized in interfacility transports. Things that they're trained on, I think a lot of people think they just give nebulized treatments, right? You get a patient in the ER, you're a nurse, patient has some wheezing, you call the respiratory therapist, and they come and fix the wheezing. They do so much more, and they're trained in so many more disciplines. Advanced airway management, yes, they are trained in RSI and intubating patients. Ventilator management, we'll go through ventilators, and right now you're like, oh, that's so hard, and then we'll go through the ventilators, and you're like, oh, that's not that bad. And then you get out there with a sick patient, and then you're like, oh, this is so hard. I wish I had a respiratory therapist with me. They learn cardiology. They learn pulmonology. They do start art lines. They draw blood gases. They analyze blood gases. They're very capable, and I think they're an excellent member to have on a team. These are some of the temporary members of the flight team. Surgeons, we have a protocol at my agency for somebody who's trapped and needs to be amputated in order to be transported. And the way it works is, in fact, I was there on the day that we did our first simulation. We came in on our helicopter to the scene, me and my medic partner, and we went, assessed the patient, recognized the need for surgical amputation. And so we contacted the hospital and our dispatch and let them know. And then we stabilized the patient. In the meantime, we have the surgeons have a ready-to-go bag of their surgical instruments that they'll need for field amputations. They even have their own flight suits. They're notified. They jump in, and then they jump into their gear, grab their bag, run out to the helicopter that's located at the hospital, jump into that aircraft, fly to the scene, and then land at the scene. And then I, as the nurse, went and met him or her as they're getting out of the aircraft, update them on the situation, the patient's condition, what's going on. Then they amputate the leg, and then they immediately jump back in the aircraft and fly back to the hospital and prepare to receive the patient. And once the leg's amputated, that's when we go ahead and move the patient, transition them into the aircraft, and go as well back to the hospital to meet the surgeon. And then I guess I failed to mention it's the flight team's responsibility, paramedic or nurse, well, as a team, but either one of them can be doing the intubating and doing the anesthesia, and that's our job. We're the anesthesiologists while the surgeon does his thing or her thing. Residents, there again, at our program, we have a resident who flies as part of her, well, she's a fellow, I guess, and as part of her fellowship, she flies as, she fills the nurse's role on flights, and she's fantastic. Perfusionists, these are healthcare professionals who, they may have associates. Typically, they're probably more bachelor's, master's degrees in whatever. Well, I shouldn't say whatever. They have a background in education in medical, biology, anatomy, physiology, that sort of thing. But the actual perfusionist part of it is certification and training. And these professionals, they work in the ORs with the physicians and manage the bypass machines. They help assist in placement and management of balloon pumps and of ECMO, and we'll talk more about these in the future. But they are, man, when you're transporting a patient on a balloon pump, if you have a perfusionist with you, you're golden. And APC, that's Advanced Practice Clinician. These are physician's assistants and nurse practitioners, and sometimes they're permanent member of the team. I have a friend who was actually a physician, a PA, an APC on one of the local flight agencies, and he worked as a PA until they stopped using the PAs. With these temporary team members, especially in the flight environment, you need to remember they're experts at what they do, but they're not used to being around the transport environment, and specifically with flying, the safety aspects of working around helicopters, flight physiology, things of that nature. So as a member of the critical care transport team, you need to keep your eye out for them and make sure that they don't do anything to get themselves killed or your patient. What did I say? Nurse-medic combo. It's the best. So medics, look at this patient here on the left. I'll bet you just pooped a little bit in your pants, didn't you? That patient looks sick. As a nurse who's worked in the ICU for years, you look at that and it's like, no big deal. We got this. And then nurses, look over at the right picture, and what do you see? Again, a little poop in your pants. That scares you. That terrifies you. And the medics are going, yeehaw, let's go. Let's ride this. They love this sort of thing. And so once the nurse and the medic both have experience in the field as critical care transport providers, and they work on scenes and they work in hospitals, they both begin to meld and they begin to be more and more comfortable in each other's world. Here are the advanced procedures that a critical care team may be called upon to perform and may be trained in, depending on your agency. Surgical airways. This is one that paramedics come standard with, new to nurses, but I doubt there are very many medics out there who have done very many of these, so it's probably fairly new to both of you. Chest tube placement and management, two very different things. Managing, we'll go through more on chest tubes, but it's not as simple as you think. I mean, you need to understand the physiology of it. However, putting in the chest tubes, depending on the patient and their anatomy and how things go for you, it could be very easy. You could also run into a lot of trouble, and you need to know where to place it depending on a hemothorax or pneumothorax or what have you. Administering blood is not as I don't know, what's the word? Inconsequential as it may sound. There are a lot of risks that come with blood product administration. So it's very tightly controlled, and you need to make sure that you are following the protocols. You could seriously hurt or kill your patient if you are not doing this correctly. Pericardiocentesis. Medics used to do this here in Utah. My dad was a medic, and they used to do this on scenes. They don't anymore, and depending on the situation, I'm not going to say that. They don't anymore. The two times that you may do this is one in a traumatic arrest, and two patients with pericardial effusions that are sending them into an arrhythmia and into cardiac arrest. Escharotomies. This is something that will be performed on circumferential burns of the chest when the skin is tightening up so much from the burning that they're not able to expand their chest anymore. Intracranial pressure monitoring. These are not placed by us. We do monitor them, however. And so you need to know the pressures that are acceptable and the pressures that are not acceptable and how to lower intracranial pressures. Intra-aortic balloon pump therapy. This is a big deal. It's a lot of equipment. When you don't just go on this with the nurse-medic combo. When we do these, you have the flight nurse, you have the cardiovascular nurse, you have the respiratory therapist, you have the paramedic, and then you have your EMTs, transporting you if it's ground transport, which they commonly are. And it takes a team. Central line management, we don't place central lines, but we do manage them. We take measurements off of them. And when patients have these, they are at a huge risk for infection. So we also need to be very careful about pushing medication into these and how we handle the line to help prevent infection. Invasive arterial and cardiac pressure monitoring. These are fantastic when you have an ART line and you're measuring the blood pressures off of it, especially when you're using vasopressors. It gives you a live reading of the patient's blood pressure. So the second it changes in the patient, it changes on your monitor, and it also comes with a waveform to assist you in determining whether these are accurate numbers that you're getting. Lab test results and diagnostic imaging. You do these interfacility transports, and you get a ton of paperwork, and on that paperwork is hopefully the labs, and labs can tell a story. So you'll learn in this course how to read labs and interpret them, and then how your treatment can change according to what their lab results are. And then as far as diagnosing or diagnostic imaging, the two that are probably most common are chest x-rays and then head CT scan. Those are the ones that you will feel pretty comfortable looking at and seeing what the problem is. Ventilators, I don't want to say they're simple. I'm not going to say they're simple. We'll learn about those. They're great. And then portable ultrasound. This is something that's coming fairly new to the industry in critical care transport. I know our agency is working towards using these. There's a lot of controversy surrounding them. But with those, you can check fluid levels in the heart. You can check for intra-abdominal bleeding. You can find veins that are, you have a big fat patient and you can't get an IV. These can assist you in finding a vein to place an IV in. And then all sorts of catheters, tubes, and drains, post-op drains, and things of that nature. So there's quite a bit. Several factors determine which mode of transportation a patient will be provided. First of all, patient acuity. Depending on if the patient has central lines, ART lines, what type of equipment, what type of infusions, will determine which agency can transport. Not all ground critical care transport agencies can transport, certain groups of patients. However, it's pretty universal that the air medical transport teams are trained and capable to take any patient, no matter their acuity. Required equipment. So equipment can take up space. If the patient's on a ventilator and your agency doesn't have a ventilator, that may prohibit. Helicopters typically don't have the amount of space that a fixed wing has, and ambulances tend to have a little more space as well. So patients who are on balloon pumps or ECMO, those types of equipment situations will also determine the transport mode. As far as time, obviously aircraft is typically going to be a faster route than by ground, unless you're transporting them like a couple miles away. So we do transports from St. Mark's and from the VA up to the U, which is a very short distance. So ground transport is what that is going to be every time. And then helicopters can be faster than a fixed wing. They don't fly at the same speed, but with the fixed wing, you also have to include time from the hospital in an ambulance to the airport, and then from the receiving airport in an ambulance to the receiving facilities. That takes up a little extra time. We have, and I'm sorry I don't have more other agencies to give you information on. This is what I know, but a lot of these apply everywhere. And so we have a base in Rock Springs where we have a fixed wing team and a rotor team. It's actually faster to go rotor because of the ambulance to and from the airport. Even though our fixed wing travels at 250 plus miles an hour, and our rotor travels around 130 miles an hour. Distance is going to decide as well. One, which I just spoke about, was like the Rock Springs situation, but any flights further than about 160 miles from the patient, those are going to go fixed wing typically, due to the fact that helicopters at that point aren't necessarily going to be faster, and you get to the point where they will need to stop to refuel along the way. And while that's not the most common way to do it, that still is an option. Weather conditions, these are limiting for both rotor and fixed wing. The weather conditions are a lot more loose when it comes to fixed wing. However, the rotor wing have to adhere to very strict weather restrictions. And then some of the critical care transport ground ambulances are also first responders in their township or in their county or in their city. And they may not be able to take a critical care transport due to the fact that they are leaving their city uncovered. And that's one factor in determining modes of transportation. And then geographic location. One thing with that is altitudes, temperatures. Rotor wing are limited, especially here in the mountainous area, by how much weight they can carry. And the higher the location and the warmer the temperature, the less weight that the aircraft can carry. You can look at these transport mode pros and cons. We're going to go more specifically through these in our aviation and ground transport operations lecture, but it's a good list here. Reimbursement. This can be a difficult topic because insurance companies, as you know, they don't like to pay. If you transport a patient with a critical care team, whether it's ground or air, you charge more. It costs more to operate those services. And if the insurance company feels that this patient did not require critical care transport, they're going to refuse to pay. And I am on the committee from our agency that writes letters to the insurance companies who have refused payment. And in my letter, I need to explain to them why it was a necessary transport. One of the things that is so frustrating to me is sometimes we are called to transport a patient who really, in my opinion, doesn't need a critical care transport. So as you fill out your report, there's a section there that where you have to justify the transport. And so without lying, sometimes you need to get a little creative to be able to justify those transports. And with interfacility transports, as far as I'm concerned, I will turn that back onto the physician who requested it. However, no matter who requested it, if it's not a necessary transport, then the insurance company is not going to pay. The federal law regulates, they don't regulate, they forbid states from regulating the rates that air medical transport agencies can charge. And this is because of an act of Congress that took place in 1978, the Airline Deregulation Act. This act was aimed at promoting private business to drive the prices of commercial travel. Well, air medical travel is technically commercial travel. Patients are paying to be transported via helicopter or fixed wing. And that is how air medical transport has fallen under this Deregulation Act. The problem with this is air medical transport agencies can charge whatever they want. There's no regulation on what they can charge, whereas the states regulate what ground ambulances can charge. You know, in the state of Utah, I think it's $1,100 is what you can charge for an ALS transport. And I'm not sure on the critical care transport, but in the air, the state has no regulation. So you get these private startup companies that it's great business for them. They can put aircraft anywhere they want, because even if they don't fly a lot, they can charge so much that that just one or two flights, pays for their entire month of operation. This is unfair to patients because, for one, they don't really have a choice on who they are going to have fly them, especially on scene flights. Whoever shows up, that's who they go with. And two, they don't, even if they did have much of a choice, which I guess they do, but they're not educated, they don't know which of these companies charge what, and which companies are CAIMS approved or have a good safety record or have good, well-trained flight crews. They don't know. And so this is a hot topic right now, and I think we'll probably see some big changes coming up here in the future. Transfer centers. Transfer centers were conceptualized in the late 90s. Their purpose is to streamline the process of interfacility transport. So if I'm a physician in an ER in a small hospital out somewhere rural, and I have a patient, a critical patient, who needs to go to the cardiovascular ICU. They're having a STEMI or whatever. I don't want to have to call a whole bunch of different people to get a bed and a doctor and transport for this patient. So I just call the transfer center. Some transfer centers are private. Some are a part of the receiving hospitals. So I know the U and Intermountain Healthcare are two hospitals in Utah, and they both have their own transfer centers. So if I want to send this patient to IMC, then I call their transfer center. I let them know what I have and what I need, and then I hang up the phone, and then they go ahead and find me an accepting physician who will then call me, and we will work out a treatment plan with this patient. They will make sure that I get a bed for my patient. They will handle communication with the transport agency, and there you go. Then a ground or flight team shows up and takes the patient away. It's nice and smooth. The communication center can be called a few different things. Some agencies will call it their dispatch center. Some agencies will call it their flight center. The FAA, when speaking of these centers in their rules and regulations, refer to it as a communication center. So don't be confused if you hear a different name for it. They're all the same thing. Don't confuse it with the transfer center. That is an entirely different entity. The communication center is either contacted by an EMS agency's dispatch center, or they could be contacted by EMS ground personnel directly, or they're contacted by the transfer center. When contacted, their job is to coordinate a flight. This involves more than just calling somebody and telling them to go. They need to gather information. They need, for scene flights, they need or prefer to get the patient's age, the mechanism of injury, in that this is a car accident, or this is a patient having a heart attack. And these rural areas, you will go on scene flights for patients who are having medical emergencies. They want to know, is this patient pregnant? So perinatal teams will transport patients who are greater than 20 weeks gestation. Our policy is, if a patient is involved in a trauma, we're going on a scene flight, and the patient is 20 weeks or greater gestation, then not only will the initial transport team go, but the perinatal team will also go. And usually the first arriving aircraft is going to be the one that's located in that region, probably not the perinatal team. So upon arrival, then that first team will decide, do we just need to load and go with this patient, or do we want to wait for the perinatal team? And they will communicate with dispatch and or the perinatal team directly to make that decision. Weight is important, especially in the warmer months of the year, because of what's called density altitude. The warmer it is, the higher in altitude you are, determines how much weight a rotor wing can carry. So another thing that's related to weight is girth. Girth is the circumference of the patient. And when you say circumference, to me, that sounds large. I don't think we think of measuring the circumference of a nice, healthy, 25-year-old male, white male, which is typically what all our studies are done on. The reason girth is important is because some aircraft, their straps typically are just not long enough to secure the patient. One of our aircraft, our 407s at AirMed, they will hold a girth of up to 72 inches. And our 145 will hold a girth up to 84 inches. So different helicopters can carry different size patients. And then they will also want to know the ground contact. Usually it's their call sign. I like to go by Maverick, but whatever they are. And then we'll also need their radio frequency. And this is so they can maintain patient updates with the ground personnel and ensure a safe landing area for the aircraft. Interfacility transports, the agency will want the age and weight of the patient again. They'll want to know the nature of the illness of this patient. Is this a STEMI patient? Is this a DKA patient? Is this a septic patient? Or what does the agency think they have, because they're not always right, the sending facility, and what they're diagnosing this patient with. And then they'll want to know, is this patient intubated or are they not intubated? And this is so that the flight crew can prepare for that. Also, any other special equipment needs, balloon pumps, ECMO, multiple infusion pumps. This needs to be this information needs to be transferred to the flight crew so they can make the appropriate preparations. And certain equipment, i.e. ECMO, balloon pumps, they also will come with our agency. They will also include a respiratory therapist on the team and a second nurse, a cardiac nurse specialist will also come. And then they'll need to know the destination that this patient is going to be transported to. And this is not just to prep the crew for what to expect, but it's also to make a determination, is it more appropriate for this patient to go via fixed wing or rotor wing?
As of April 22nd, 2016, the FAA has mandated that every air medical company that's operating more than 10 helicopters or 10 EMS providers, whether helicopters or airplane, is going to have an operational control center. The operational control center is responsible for approving every flight that comes through if they feel it's safe and can be done. So the way the process is going to work is a flight's going to come into our dispatch center, or also known as our communications center. They're identified by the FAA as the communications center. Anyways, when the flight's going to come in, it's going to go from there. They're going to put in the coordinates, and they're going to send that over to the pilot. Pilot's going to get the flight. He's going to check the weather, check all the obstacles, identify any hazards, fill everything out. From there, talk with the crew, make sure the crew's comfortable with it. When the crew and the pilot are all comfortable with the flight and feel it's acceptable to take, pilot's also going to fill out a risk.
So tell us about the risk.
The risk is basically just going to identify any hazards along the flight.
So this is like a form that you fill out?
Yep, form. Basically, highest obstacle along the route, like when's the last time the pilot slept, when the last time he's eaten, had water, rest, relaxation, how much fuel you have, or do you have your minimum fuel, or are you carrying more? Do you plan to have a fuel stop in between? Different types of risks, as well as weather and everything like that. So after he fills out that risk assessment, he's going to sign that, and then he sends that to what's called our operational control center. Now, they have the final authority as far as accepting the flight. They can look at all the information that the pilot sent over, and if they're still not comfortable and they go, hey, we looked at the weather, we don't think that thunderstorm is going to be moving out of the area like you do, they can decline the flight.
So they can override a pilot?
They can override a pilot to decline a flight. They can't make us take it. So say that same flight comes in and I go, yeah, I'm not really comfortable with it. In all reality, OCC would never know about this. They wouldn't actually get the flight. But say for some reason they heard about it, they would not then be allowed to call us on the phone and go, no, weather's fine, you have to take it. OCC cannot make us take a flight. All they can do is decline a flight.
So you got the devil on one side, and that's a communication center. And you have the angel on the other, and that's OCC, and they're super good and super conservative. And that was a bad example.
Was.
But they're the ones who say,
I would not tell our
"Don't
flight center you
do
called
it."
them the
They're
devil.
your conscience.
That's right. Exactly. So, yeah. So with that, the OCC basically, they have the final authority to decline a flight as far as once that begins. So
I got it.
they can also be used while in flight to help recheck weather. If we need to divert, we can use them to add new information to any type of in-flight weather or advisory we need, we can actually receive from OCC over the radio as well.
And they can now spy on you.
And now everything is being tracked. So that is part of it. The OCC is supposed to be watching the entire flight as well. So that's one of the things the FAA put in. So when we take off, they're actually monitoring us the entire flight.
So you got to watch what you say.
Watch what you say. Everything's being recorded. All the instruments are recorded, as well as our flight data is being tracked, as well as the actual route is being tracked. And this is actually the same as how airlines are going to operate. Airlines also have an OCC. Prior to every pushback at a gate, when you hear an airline pilot talking like that, they cannot push back until they've talked with OCC and got approval, which is the same as an EMS operation as well now.
Maintain good communication with your patient and with their family members. When you initially enter that room, introduce yourself, introduce your partner. That will help get things off on the right foot. Allow them to participate in the planning for this patient, answer their questions, and keep them involved in the process. Don't kick family members out unless there's a good reason to. Allow them to remain with their loved one as they desire. It's also important before you leave with the patient that you give family members an opportunity to spend a brief amount of time with them. This may be the last time that they see that family member, and you should not take that opportunity away from them. It's important to get going quickly, yes, but don't deny the family time to pray with the patient if they wish, or to provide the patient with a blessing. Your job is to save this patient, but not at the expense of hurting the family. By maintaining good communication, you're actually less likely to be involved in a lawsuit. This family will be less likely to come after you legally. And their perception of you is not necessarily from how well you perform your job as a clinician, starting IVs, hanging drugs. Their perception of you comes more from how you treat them and how you communicate with them. And this goes for the staff members as well at the hospital. If you want to come back to this hospital, you need to maintain good relationships with them. Treat them respectfully, even if, they're not doing things that are right for the patient and actually doing things that are harmful. Don't make them feel stupid. Be kind and be compassionate. Critical care transport programs require a medical director. This could be an ER physician, anesthesiologist, an intensivist, any number of physicians that are involved in their practice in managing critical care patients. There also can be more than one member of this medical team, which is a good idea. It's nice to be able to have physicians with different sets of skills and expertise. It gives the program more depth. The program medical director or medical directors have a number of different hats which they wear. They are heavily involved in ensuring that the team members are competent, are knowledgeable, are capable of performing the skills that are required of them. And part of this comes from being involved in the quality management program that CAMES requires agencies to have. We'll talk more about that type of a program in one of the upcoming slides. Program medical directors should be actively involved in hiring new transport providers and being involved in their education and in their training. The medical director is also responsible to make sure that flight team members have a medical control doc at all times. There are a number of situations where it's necessary to contact a medical control physician. Some of these include situations where deviation from written protocols or standing orders is necessary, situations where the patients are so complex that it exceeds the knowledge or the capability of the critical care providers, and specifically medical control can back up the team when they are running into issues with sending or accepting providers regarding orders for patient care during transport. CAMES standards for rotor pilots. All right, so the rotor pilots have to meet stringent requirements. They need to have a total of 2,000 flight hours, and 1,200 of those hours needs to be in a helicopter. Some pilots fly both fixed wing and rotor wing, and that's why they specify you do need to make sure at least 1,200 of those hours are in a helicopter. 1,000 of their hours needs to be flying as the pilot in command, which if you're flying in a single piloted aircraft, that pilot is the pilot in command. But there are situations where you have two pilots flying in a helicopter. One of those pilots is the pilot in command. Once they get to the program which they're flying for, before they accept a flight alone, they need to have 5 hours of basically flying orientation in the geographical area they'll be flying in, and 2 of those 5 hours needs to be at night. And then, while not required by CAMES but strongly encouraged, and I know especially around here the flight agencies do require their pilots to be instrument rated. So that means that if they were to be flying in conditions where they could see, and then all of a sudden the weather changes and they are now flying what's called IFR, or instrument flight rules, where they can no longer see or their visibility is severely limited, that they can fly the aircraft safely using just their instruments, which is easier said than done, apparently, and we'll talk more about that on another lecture. CAMES standards for fixed-wing pilots. All right, so here we have 2 different tables. One's for single pilot operation and one's for dual pilot operation. There's a lot of numbers to remember. Just to break it down, so for the single pilots, they have to have 2,500 total hours, okay? And then if they're flying a multi-engine, they need to have 500 hours flying a multi-engine aircraft. All 3 of them need to have 1,000 hours as the pilot in command, which is the same with the rotor. And if you look here, the only one that needs to have more than 1,000 hours of pilot in command time is down in the dual pilot operations for multi-engine turbojet. That's the only one that needs extra time. The rest, pilot in command hours, are 1,000. I'm just focusing on this because you may see it on a test. Again, back to the single pilot ops. So they need to have, for the single engine turboprop and the multi-engine piston, they need to have 50 hours of flying that specific aircraft. And then the multi-engine turboprop, they need to have 100 hours flying that one. Then if we come down here to dual pilot, again, 2,000 total hours. So not quite as many hours required if you're flying dual pilot operations, 500 less actually, except for multi-engine turbojet, which I've never seen that on a test, but there you go. Then multi-engine hours for multiple engines is 500, so that's the same whether you're in a dual or a single pilot aircraft. And pilot in command time we talked about, and then second in command time. So this is when you are the second pilot who's not a pilot in command. Also never seen this on a test, but there's those numbers: 500, 500, 800, 1,000. So rest is a big deal for pilots, and when you're a flight crew member, it becomes a big deal for you as well. So 10 hours of rest prior to shifts that are 12 hours or longer, this rest is technically 10 hours of not working as a pilot, or if you're a crew member, not working at another job, even if you're a firefighter, right, is your other job, and you slept all night and it was no big deal. You're not supposed to do that. You're not supposed to come in right when you get off a night shift, even if you slept all night. And I know a lot of times, because of scheduling is hard, that some programs may just look the other way. Shifts longer than 12 hours. So the agency you work for, if your shift goes over 12 hours, they have to provide uninterrupted rest after you've taken care of your daily duties, like inspecting the aircraft, inspecting the gear, having your daily briefing, anything, related to your job. You have to have the opportunity to rest. And that means that the agency has to provide you with a bed and a quiet room where you can do that. Shifts that extend greater than 24 hours or for multiple days is frowned upon, but CAMES does allow it in certain circumstances. First of all, you have to use a fatigue risk assessment tool. So your agency would have one of those that when a flight comes in, you've got to go through and check and make sure everyone meets the requirements for having enough rest. And this is things like how much flight time have you had during the shift, when was your last flight, things like that. This is allowed only when the base is in a location that requires extended commuting, right? So this is a way to staff rural bases with good, experienced personnel. When they have to drive a long way, sometimes you're not going to find people that are willing to drive a long way, 3 times a week. So they have those extended shifts. I know of companies that have 48-hour shifts. I know 72-hour shifts, and I know even I've heard of 7 days straight as flight crew members, depending on the company and the base. Crews must have the right to call timeout without fear of disciplinary action, regardless of how long the shift is. So even 12-hour shifts. I have been involved on shifts where this happened. One time it was me. I actually took a medication the night before that was new, and it made me so groggy. I don't know how I got to work alive, but I did. And during the briefing, the pilot noticed I couldn't stay awake, and he called it for me. He's like, "I'm calling a timeout. You need to go get rest." So we went out of service. I lay down for a few hours. My boss called me to see if everything was all right, but there was never any pressure to get back in service quickly, or there was no punitive measures. I also had a friend who incidentally had just gotten off a night shift or a 48-hour shift as a firefighter, and he didn't get a lot of sleep. And so, got there and he's planning on just getting the shift duties done quickly, get things checked off, and then taking a nap. Well, we got a flight immediately. And then we got another flight. And I remember during that flight, I can't remember specifically what the drug was, but there was a drug or a dosage mess up where he started to push something. And I said, wait, is that this? And it was wrong. He had made a mistake. It was in the middle of the flight, and he set it down and he said, "That's it. As soon as we land, I'm calling a timeout." And so we landed, got the patient settled, and then flew back to the base, and we went out of service, and he got a nap. And when he woke up, he felt like he was a lot more functional and never any discipline. So, I could see this rule being bent a little by agencies who have a strong drive to make money, where they may be pushing the crews to get back in service quickly. However, that's not supposed to happen, and I have never known of that to happen for anyone that I have worked for. That being said, obviously this could be abused, and I have known of situations where people just didn't want to take a flight, so they took a timeout. So don't be that person. No one wants to fly with that person. Emergency Medical Treatment and Active Labor Act, EMTALA. Okay, so this was a part of the COBRA Act, which was passed in 1986. It was a big federal law, that covers a lot of budget and health policy stuff. The two pieces that we mainly care about are, first, the part that most people recognize. COBRA lets employees keep their employer health insurance for a limited time after they lose a job or have certain life events. That doesn't really apply to our job, but that applies to you as a human living here in the United States. The second part, and this is what matters for us, is the EMTALA law that lives inside COBRA. The EMTALA part of this act was put in to prevent hospitals from refusing care based on a patient's ability to pay. So this practice was called patient dumping. And before EMTALA came, this was actually a fairly common occurrence. So one of the cases that was brought before Congress, there was a woman in active labor in Texas in the early 80s, and she showed up at a private hospital, and she was uninsured. They examined her just enough to know that she was actually in labor. Then they promptly put her in a cab and sent her to the county hospital across town. While en route, she delivered in the cab. Another example came out of Chicago where shooting patients or MVCs were routinely transferred out of the private hospitals once the staff realized they had no insurance. Some of these patients were moved before they were even stabilized, sometimes while they were still bleeding out. County hospitals became basically a de facto safety net where these patients would get sent late in their course, already worse off and more likely to die because the time and resuscitation opportunities had been lost. So back in these days, the hospitals would just call for an ambulance. Ambulance gets there and they'd say, hey, this patient needs to go to county. Not calling county at all to even let them know they're coming. Or even worse, they'd just call a cab and put the patient in a cab and say, take him to county. So now every emergency department has to provide patients who request it a medical screening exam where they do a full workup to determine whether or not there is an emergency. And they cannot refuse to examine or treat any individuals based on their ability to pay. So, and I've seen this at the hospitals that I work at where you'll have a patient in the ICU who has no insurance, is going to require long-term care, and you can't find a skilled nursing facility or a long-term acute care facility that will take them because of their inability to pay. And so the patient sits in the ICU and eats up hospital money, which of course they pass on to us, the consumers, later. But it's scary how much money plays into this still. But as far as emergency departments go and ICUs, you can't just ship patients out anymore. Obviously, patients can be shipped out of hospitals, or we wouldn't have interfacility transports. But they do need to meet certain criteria. So here is the criteria that is required. So the patient has to consent to being transferred to another facility. The benefit of transferring this patient to a different facility outweighs the risk. The sending facility provides pre-transfer treatments to minimize risk of transport. So they perform that medical screening examination and they stabilize the patient to the best of their ability. The receiving facility has to have a physician who accepts the patient. They have to have an available bed, and they have to have the available resources, meaning enough, staff on hand to take care of the patient. And then before the ambulance is even called, the sending physician has to speak with the receiving physician and give a full handoff. The receiving physician has to accept, and then they have to have all the resources and the beds available. The transport method must be appropriate to the patient's condition, so you shouldn't have an EMT ambulance transporting critical patients. All the pertinent records outlining the care that patient received from the sending facility has to be taken with the transport team to the receiving facility. So this would be things such as lab values, radiology, imaging and reports, physician reports, things like that. And this includes an EMTALA document that if it is not filled out appropriately, it's not your job to make sure that it's filled out appropriately, but if it's not filled out appropriately, the physician and the nurse sending the patient can be personally fined. I don't know exactly what the fees were, but at one point they were like up to $50,000. Then there's this little rule called the 250-yard rule. So as you can imagine, hospitals then decided, well, if you're not actually in the ER, then EMTALA doesn't apply. And situations where, somebody out in the parking lot collapses, is it the ER's responsibility to care for them? Yes. So the rule is if you are on the hospital property within 250 yards of the emergency department entrance, that ER is responsible for caring for you. So, Intermountain Medical Center in Murray is a huge campus, and there's a Costco on the corner, which is actually owned by the property is actually owned by the hospital. And so if you were to collapse in that Costco, I would imagine the emergency department is responsible for you. That's pretty close to 250 yards. So that's where that rule came from. Now, as a transport provider, it's not your responsibility to enforce it, but you are transporting the paperwork, and with that is an EMTALA sheet that needs to be filled out. So you should look at that, make sure you have it. Your agency very well may require you to upload that as part of your documentation of the call. Now, here's an interesting dilemma that this creates. So when an ambulance is transporting a patient from a scene with the intent to rendezvous with a helicopter on the pad of a hospital, even if it's not, that pad that helicopter is based at, right? So the helicopter's coming from such and such town, the ambulance is coming from somewhere else, and they meet on the helipad. As long as the plan is not this patient is going to be seen in the ER, then in that case, that hospital pad is simply a landing zone, and it doesn't trigger EMTALA. Now, if hospital staff comes out and initiates assessment or patient care, that may trigger EMTALA to where now the patient needs to go inside and have a medical screening and be stabilized by that hospital. So there are times where this is not good, because this patient just needs to get, to a trauma center. And now you're going to delay that by finding a bed, doing a doc-to-doc, doing a medical screening, which may include a head CT, right? So that can be a problem. This can be a messy area. There was an incident here in Utah where the plan was to rendezvous at the pad, and this is a trauma patient from a crash on the freeway, and the doctor came out and wanted to poke their head in and see what was going on, and the EMS crew member would not let them, and actually slam the doors in their face and would not let them in back of the ambulance. The patient ended up dying, and the question is, well, did this patient require stabilization while waiting for the helicopter that could have saved their life? And I don't know the answer to that, but the ambulance crew can't just completely deny the hospital and say, nope, you can't come in. I mean, obviously there should be some dialogue there and decide what's best for the patient. In that situation, the helicopter was delayed, and it sounds like the patient could have used some blood and stabilization inside the hospital while waiting for the helicopter. So incidentally, the family of the patient sued the county ambulance service, or is currently suing, I'm not sure, and they also sued the provider who would not let the hospital staff into the back of the ambulance. All right, everyone, that does it for Concepts of Critical Care Transport. Thanks for listening.